Chapter 41, Diabetes Mellitus. In this chapter, we'll talk about anabolism and catabolism, and then we'll discuss the role of the pancreas in maintaining our body's homeostasis, specifically focusing on insulin hormone and bringing diabetes mellitus into the conversation. So anabolism and catabolism. So the process of anabolism or anabolic pathways is to build up. So what we're going to do is we're going to take individual foodstuff, in this case, glucose, amino acids, free fatty acids. These are solutes that are dissolved in the blood, and when we want to build it up, store it, we will do that in our cells. And so glucose, when we store glucose, and we combine glucose with glucose with glucose, we will store it as glycogen. Amino acids, when we attach to other amino acids, we build proteins. And then free fatty acids, along with a glycerol backbone, becomes our triglyceride. So anabolic pathways will promote taking the individual foodstuff that's available in our blood and allowing us to store it, so create something bigger that we can then store inside of our cells. Hormones that stimulate anabolism includes insulin, which we'll discuss today, as well as anabolic steroids. To move the other direction, we will undergo catabolism. So catabolic pathways take something big and it breaks it down into the individual pieces. So it'll go in the opposite direction. So taking glycogen from our cells and breaking it down so that glucose is then released into the blood is a catabolic pathway. Taking proteins in our cells and breaking it down, we get our individual amino acids, and then our triglycerides, we can break them down into free fatty acids. This process will be promoted by the hormone glucagon. So insulin and glucagon, both secreted by the pancreas, are antagonistic hormones that have the opposite impact on our body. Other hormones that promote catabolism includes epinephrine and cortisol, which are hormones that you are already familiar with. One thing I want to keep in mind is the available foodstuff, especially our glucose, is required for our cells to be able to utilize that glucose for energy. Just keep in mind that our brain requires glucose, but when glucose gets very low, when we have hypoglycemia, the liver can convert amino acids and free fatty acids into ketones or ketoacids, and our brain could utilize that for energy as well. So one thing I want you to recognize from this slide is we always talk about insulin in relation to glucose, but notice it also does impact our amino acids and free fatty acids. So 2 women have benign pancreatic tumors. So what differences do you expect to see in these women? Well, in one, the tumor is an insulinoma and it's just making too much insulin. In the other woman, the tumor is a glucagonoma and it's making too much glucagon. So what would you expect to see in the woman who has an insulinoma? The woman who's making too much insulin, you're going to have too much anabolism. So she's going to be storing her individual foodstuff out of her blood into her cells, so her blood glucose, if we were to look at it, would be low. She would be hypoglycemic. On the other hand, the woman with a glucagonoma will have too much glucagon, which we said is antagonistic to insulin, so she has too much catabolism happening. So she is breaking down the stored foodstuff from her cells and releasing it into the blood. So her amino acids, her free fatty acids, and her blood glucose would be elevated. Now, both women have arthritis, but only one is being treated with a corticosteroid. Which one, and why is the other one not receiving corticosteroids? Well, remember, cortisol also increases blood glucose. So you wouldn't want to give it to the woman who already has too much catabolism happening. So the person with insulinoma, the woman with insulinoma, will be treated with the corticosteroids. It would be contraindicated for the woman with the glucagonoma. Now, these hormones, insulin and glucagon, are released by the pancreas. Now, the pancreas is quite interesting because it's both an exocrine gland and an endocrine gland, so it has both functions. So the endocrine pancreas is what we're going to start off talking about. It's going to release hormones into the blood, specifically insulin and glucagon. We'll talk about the exocrine pancreas later on. It's going to release, remember, exocrine glands release substances through a duct into a lumen. In this case, the exocrine pancreas releases digestive juices, so enzymes that help with the process of breaking down our foods in our small intestine so that we can absorb it. So it gets released into the duodenum. So let's focus on the endocrine pancreas first. So it's made up of a bunch of cells, a group of cells that we call the islets of Langerhans, and that's made up of alpha cells, which secretes the hormone glucagon, beta cells, which secretes the hormone insulin and amylin, delta cells, which secretes the hormone somatostatin, and F cells, which secretes pancreatic polypeptides. So really we're going to focus on the glucagon and insulin, but be aware of all of these other hormones. So glucagon, again, is secreted by our alpha cell. It's easy to remember because glucagon has an A in it for alpha. It causes cells to then release stored food stuff into the blood. So if we're looking at blood glucose, it's going to increase blood glucose levels. Insulin, on the other hand, secreted by our beta cells, allows our cells to then take up blood glucose and then store it in our cells as glycogen. So it will cause a decrease in blood glucose levels. Now, the way that insulin is released is in a biphasic manner. So we can see that here. So there's like an initial peak of insulin release, about 3 to 5 minutes. So it's an acute phase. And then the second phase begins at about 2 minutes, and it'll continue to increase for at least an hour or until the stimulus is no longer there. Amylin, remember, is also released by the beta cell. So the beta cell not only releases insulin, it also releases amylin. So it's safe to think of these two hormones as having a similar impact on blood glucose. And it does. Amylin also lowers blood glucose levels. It just does it differently. So what amylin does is it slows glucose absorption in the small intestine. So if you decrease how quickly glucose is absorbed in the intestine, then obviously that's going to help keep our blood glucose from rising. So it helps kind of keep it lower in essence. It also suppresses glucagon secretion, and we know glucagon raises blood glucose. So again, it's a way to help not raise blood glucose. And then somatostatin just kind of stops everybody. So it decreases your GI activity. It also suppresses glucagon and insulin secretion. Now, insulin, again, promotes anabolism. It will enhance, I'm going to start with number 3 and 4. It'll enhance the utilization of amino acids. So then we're going to take the amino acids, build protein, so it decreases blood amino acids. It also promotes fat synthesis. So we're going to take our free fatty acids and then create our triglycerides. And we know it lowers blood glucose, and it does it 2 ways. Number 1, it increases glucose transport into most insulin-sensitive cells. So a cell is sensitive to insulin if it has the insulin receptor. And so what this is saying is glucose is very large. It has an atomic weight of 180 atomic mass units. So it has to go through a glucose transporter. What insulin does is when it is released, it binds to insulin receptors on cells, and it causes those cells to exocytose the glucose transporters or GLUT transporters and insert them into the membrane. And now that GLUT transporters are in the membrane, glucose will diffuse from an area of high to low concentration. So since insulin is released when blood glucose is high, glucose will travel from the blood into our cells. Now remember, this is an example of facilitated diffusion. And facilitated diffusion stops when you reach equilibrium. And so that's where number 2 comes in. Number 2 says insulin enhances cellular utilization and storage of glucose. So what that means is insulin not only causes you to put the GLUT transporters into the membrane so we can bring in glucose, it then causes the cell to then store the glucose. So if we take glucose and store it, we're decreasing the concentration of glucose inside our cell, so that'll keep the concentration gradient going so that we can keep bringing in more glucose from the blood into our cells. So number 1 and number 2 really work together to help lower blood glucose. Now think back on your day so far. When do you think you had your highest insulin levels? Well, your insulin levels would be highest when you need to lower blood glucose. So when is your blood glucose highest? It's right after you've had a meal, especially a high carbohydrate meal. When do you think then you had your lowest insulin levels and then as a result highest glucagon? That would be when you don't want to lower blood glucose, which is probably in the morning before you've had breakfast. Now, if someone lacks insulin, what do you think is going to happen to his blood glucose levels? So remember, insulin lowers blood glucose. So if he doesn't have insulin, then his blood glucose is likely to rise. What would happen to his amino acid levels? Now remember, think back to that first slide. Insulin doesn't just impact glucose. It also impacts amino acids. And so amino acid levels will also rise. What will happen to his blood pH? Well, amino acids are acids, so his blood pH will decrease. It'll become more acidic. What about his intracellular fat level? So now we're moving away from the blood, now we're moving into our cells. So his intracellular fat levels would decrease because insulin is not there to promote the storage of fat. Intracellular protein levels will decrease, and then as a result, overall cell growth will decrease. Now here's that first slide that we talked about, and here I have a figure of sort of the mechanism of action of insulin. So this is just to remind you what insulin does. It promotes anabolism. And here we have insulin. It's shown in these purple diamonds, and this is your insulin receptor. So this is the cell membrane of a cell, so this would be considered an insulin-sensitive cell. And the point of this is to show you that insulin, to work, it actually requires a lot of things to work as well. So the receptor has to be working and receptive. Then it turns on a tyrosine kinase and other signaling proteins, which all have to be working as well. The GLUT transporters have to be functional. So it's not just about having insulin. The point is there's a lot of other proteins and enzymes that are involved as well. So we're going to identify things that could go wrong to cause increased blood glucose. So what could cause hyperglycemia? What would have to happen to insulin? So if we know that insulin lowers blood glucose, having a decrease in insulin would then raise blood glucose. So a decrease in insulin, loss of insulin, not enough insulin being secreted would raise blood glucose levels. What about epinephrine, glucagon, and cortisol? Now, epinephrine, glucagon, and cortisol all raise blood glucose. So having too much of them, a rise in these hormone levels would also increase blood glucose. So what this demonstrates is that diabetes mellitus can be secondary to other endocrine disorders. So if you have an endocrine disorder where you're making too much cortisol, that's also going to raise your blood glucose. And finally, we have defects in any of the proteins that are involved in insulin action. That will also raise blood glucose. For example, if the insulin receptor isn't working, it doesn't matter how much insulin you have, it's not going to function. So you won't be able to lower blood glucose. As a result, blood glucose will rise. So again, this shows that there could be multiple genetic causes of diabetes mellitus. So which of the cases that we identified above would be least likely to respond to exogenous insulin? Well, basically, which one's not going to respond to taking insulin? Well, if you have low insulin, taking insulin, that makes sense. It's going to replace it. It'll help. If you have too much epinephrine, glucagon, and cortisol, giving insulin could compete and help. But let's say you have a defect in insulin receptors. So then no matter how much insulin you give, it's not going to work. So this would be the one that would not work. So defects in the insulin receptor or the glucose transporter or the tyrosine kinase or any of the other signaling proteins that are involved in the action of insulin, if that's the issue, then giving insulin wouldn't work. So let's talk about glucose intolerance disorders. So diabetes mellitus. We have type 1 and type 2. So type 1 diabetes mellitus is where your pancreatic beta cells are getting destroyed. So the cells that are making insulin are destroyed. It's predominantly due to an autoimmune disease. So your own immune system is destroying your own beta cells. This is also known as insulin deficient diabetes because you are deficient in insulin because your beta cells are getting destroyed, or juvenile onset. Because typically, if you are diagnosed with diabetes as a juvenile in adolescence, it's because you have type 1, although we know that's not really the case anymore because a lot of kids now are getting diagnosed with type 2 diabetes mellitus, which is a combination of beta cell dysfunction. So your beta cells are starting to become dysfunctional, so you may not make as much insulin as normal, as well as insulin resistance. So this is also known as insulin resistant diabetes. So there are other specific types. It could be due to genetic defects in the beta cells or in any of the things that are necessary for insulin action, or it could be a disease of the exocrine pancreas that's actually destroying the endocrine part of the pancreas, or it could be secondary to other diseases. We said other endocrine disorders may cause glucose intolerance, or drugs, chemicals, or an infection could have induced it as well. And then we have gestational diabetes mellitus. This is when glucose intolerance is first recognized and diagnosed during pregnancy. So let's talk about type 1. So type 1 is where you are insulin deficient. And again, that's because your pancreatic beta cells are getting destroyed, typically due to an immune mechanism. Although, even though the etiology may be immune mediated, it could be idiopathic without any autoimmune markers. About 5 to 10% of the people who have diabetes mellitus have type 1, and it's usually diagnosed during adolescence, so between 5 and 20 years of age. So if you have type 1 diabetes, you're not making insulin, then you're going to start to see hyperglycemia. So your glucose levels are going to start to rise in your blood. And when your blood glucose levels begin to rise, we're going to start to see that in your urine. So we will filter glucose in the kidneys, and when we have a lot of glucose, it may exceed the renal threshold for glucose, which means we're not going to be able to reabsorb all of the glucose back into our blood, and so some of the glucose will remain in our urine and show up in your urine, and that's called glucoseuria. And remember, water follows solutes, and glucose is a pretty good solute or a pretty big solute, so having more glucose in the urine, in the tubules, means it's going to hold on to more water, and so that's going to cause us to create a lot of urine, so it leads to polyuria, which is excessive urination. And if you're urinating a lot and losing a lot of fluids, you're going to become dehydrated, so it leads to polydipsia, which is excessive thirst. And it also can lead to polyphagia. So when you have glucose that's remaining in the blood and not actually getting into your cells, your hypothalamus, which controls hunger, will essentially think that it's starving, and so it'll make you hungry. So that's where the polyphagia comes in, excessive hunger. And you can also get ketoacidosis. So the glucose isn't getting into our cells, and remember, our brain needs glucose for energy. However, if it can't get it, the liver can make ketones or keto acids for our brain to use for energy. And so then we start to make these keto acids, and that leads to ketoacidosis. So this is an example of metabolic acidosis because it has nothing to do with a respiratory problem. Type 1 diabetes requires exogenous insulin replacement. So if you are insulin deficient, replacing that with insulin that you are giving will help as a treatment. And it'll reverse the catabolic state, control blood glucose, and prevent ketosis. Now, what about type 2 diabetes mellitus? So this is the insulin-resistant type. This is where your tissues stop responding to insulin. Now, there could also be a lack of insulin or impaired insulin released by beta cells that have become dysfunctional. Now, majority of people who have diabetes mellitus have this type, so 90 to 95%. And it's becoming more and more common in the young, so obese adolescents and children, especially non-Caucasians, are disproportionately affected, as well as elderly. So as you age, we typically see this starting to develop. Now, insulin levels could actually be normal or even elevated initially, and then eventually, as this disease progresses, you can become insulin deficient. And so why could it be normal and elevated initially? Remember, our cells are not responding to the insulin, so our beta cells may still be producing normal amounts of insulin. It's just our tissues are not responding. And so as a result, our beta cells may produce more insulin to try to kind of fix the problem as a way to compensate. And that's why we can actually get an elevated insulin. And then eventually, as our beta cells are working really hard to produce a lot of insulin, it can become dysfunctional and become insulin deficient as well. So the pathophysiology involves both genetic and acquired factors. So a family history can increase your risk, but there are acquired factors, so risk factors that we can control. And this is really related to lifestyle. So it's an epidemic that's attributed to our sedentary lifestyle, the fact that we have such an ample food supply that as a country we are overweight and obese. Polyuria, excessive urination, polydipsia, excessive thirst, and polyphagia, excessive hunger, may be more subtle, and ketoacidosis is pretty uncommon with type 2 diabetes mellitus. Now, the pathogenesis, again, of type 2 diabetes is we have our impaired insulin secretion, which can happen. We may be producing too much glucose through the liver, so hepatic output of glucose may increase as a way to compensate, because our brain, again, thinks we don't have enough glucose that's actually getting into our cells. And then we have too much carbohydrates being produced. So, we have too many carbohydrates being absorbed in the small intestine. So this would be related to our food intake. And we may, again, have decreased insulin-stimulated glucose uptake. So our insulin receptors are not responding. We're becoming resistant to insulin. So all of these are contributing to the development of type 2 diabetes. So how can we help treat this? So we'll pretty much try to combat each of these. So to decrease the hepatic output of glucose, we can give biguanides. Now, if you look over here, we have a major and a minor effect. Focus on the major effect. So the major effect of biguanides is to decrease hepatic output of glucose. And then the major effect of thiazolidinediones is to increase the peripheral uptake of glucose by our tissues. And then we have alpha-glucoside inhibitors that can decrease glucose absorption in the intestine. And then beta cell stimulators to stimulate our beta cells to release more insulin. And all of these strategies can help us regulate our blood glucose and treat type 2 diabetes. Now, another thing that you may see with people who have type 2 diabetes is metabolic syndrome. So it's basically a combination of type 2 diabetes, atherosclerosis, and hypertension. Now, you have to have at least 3 of the 5 following criteria to be diagnosed as having or categorized as having metabolic syndrome. And the first one is central obesity. So this is the obesity around your midsection. So for men, it would be 40 inches or higher, and then for women, it's 35 inches and higher. So if you measure yourself around your midsection and you're a female and you're greater than 35 inches, then you have one of the criteria. There's also elevated blood pressure, so greater than or equal to 130/85, or if you're taking hypertensive medication. So even if your blood pressure is at normal, if it's at normal because you're taking meds, then you still have that criteria. And then increased fasting blood glucose, greater than or equal to 110 milligrams per deciliter. Normal is about 70. And then elevated fasting plasma triglyceride levels, so above 150 milligrams per deciliter, or again, if you're taking medication. And then if you have low levels of the good cholesterol, which is our HDL, so lower than 40 milligrams per deciliter in men and 50 in women. Now, 60 or higher is what is desirable. And then gestational diabetes mellitus. So this is, again, when you first detect glucose intolerance during pregnancy. And it really closely resembles type 2 diabetes mellitus. And if you have gestational diabetes, your risk of eventually developing type 2 is a little bit higher. So you really want to watch your lifestyle. It's most likely due to the presence of all of the extra placental hormones. And it occurs in about 2 to 14% of pregnancies. And it's mostly in women who have a history of diabetes in their family or glucosuria, who have a history of stillbirth or spontaneous abortion, who's obese. And then if you are of advanced maternal, and obesity is it's even, you don't technically have to be obese. There's an elevated weight. There's actually a chart that goes into it, but overweight. And then advanced maternal age, as well as having multiple pregnancies, so 5 or more pregnancies. So these would increase your risk. But again, you can have all of these and not develop it. And because it closely resembles type 2, you really try to manage it through diet, exercise. But if you can't, then obviously medications will help manage your blood glucose so that you don't negatively impact your health and your baby's health. So what about some complications related to diabetes? So we've talked about this. How would hyperglycemia with ketoacidosis cause heavy breathing? So we know we have hyperglycemia with diabetes, a lot of glucose in the blood, and it's not getting into our tissues like our brain, so our liver will make keto acids. So why would that cause heavy breathing? Because we talked about acidosis. So too many acids, one of the ways we correct for that is through our respiratory system and to breathe out CO2, because CO2 in our body is like having acids in our body. So the acid will stimulate chemoreceptors that'll increase our respiratory rate to try to get rid of carbonic acid from the blood, which will then help return our blood pH to normal. Now, why would hyperglycemia and ketoacidosis lead to polyuria and dehydration? Well, all of that glucose in the blood eventually shows up in your urine. And with more solutes in your urine, we're going to hold on to more water and increase urination or fluid loss through our urinary system. And that means we're going to lose water in our blood, causing us to become dehydrated. Now, what about obviously, osmolarity gets altered with diabetes mellitus. So when blood glucose is really high, we're going to have increased osmolarity because there's more solutes in the blood. So we'll have a hypertonic solution. Now, if you have a hypertonic solution, what does that do to your cells? Remember, water follows solutes. So water will leave your cells into the more hypertonic blood. Now, our cells don't want to lose water and shrink, and so what it'll do is it'll make extra intracellular osmoles, or it'll make intracellular solutes to increase the osmolarity inside the cell to try to hold on to the water. So when you want to bring a client's blood glucose back to normal, you want to make sure that you do that slowly so that our nerve cells that made these extra solutes have time to destroy them so that we don't have water moving the other way. So if we were to lower our blood glucose too quickly, all the extra solutes that were made in our nerve cells would then draw water into the nerve cell and cause them to swell. So whether your nerve cells shrink or swell, either way, it's not a good thing. And so it makes sense that our cells can become damaged with diabetes. So here we have diabetic neuropathy, so damage to our neurons due to diabetes. So it could be any neurons, so the somatic neurons or the autonomic. So if we have somatic neuropathy, we'll have diminished perception of vibration, pain, temperature, and hypersensitivity to light touch, as well as occasional severe burning pain. If you have damage to autonomic neurons, so autonomic neuropathy, the consequences will be autonomic in nature. So defects in your vasomotor response, your cardiac response, issues with GI motility and GI activity, issues with bladder emptying, and sexual dysfunction. So we're going to end this section with a worksheet that goes over diabetes. So let's follow along. If you have decreased insulin secretion, what will that do to your cells? Will your cells take up less or more food from the blood? So if you don't have a lot of insulin, you're going to take up less food from the blood. And if you take up less food from the blood, that means it's going to remain in the blood, so you will become hyper or hypoglycemic. So more glucose in the blood means you are hyperglycemic. If you have hyperglycemia, is that going to increase or decrease your glucose in the urine? So if you have a lot of glucose in the blood, we know it eventually shows up in your urine. So you have increased glucose in the urine, which means you're going to increase urine volume because water follows solutes, and that leads to osmotic diuresis, so increased urination. If you have hyperglycemia, that means your blood osmolarity will also be high because of all those solutes. And water follows solutes, so water will then leave your cells into the blood because it's more hypertonic. And if water is leaving your cells will shrink. And obviously that can contribute to confusion, maybe putting you into a coma. But if your cells are shrinking, your hypothalamus will create a sensation of thirst. And that will lead to polydipsia, so that you're constantly drinking to try to replace the water. And if we go back up here, if your cells take up less food from the blood, it's also going to take up less amino acids and free fatty acids, so those levels will increase in the blood. And the more free fatty acids and amino acids you have in the blood, your blood pH will lower, become more acidic. And if you recall, if you have more hydrogen ions, it's going to decrease nerve firing. Remember, hydrogen ions can block sodium channels. We talked about that previously. And if you have less nerve firing, that will also contribute to confusion, maybe putting you in a coma. And if you have low blood pH, if you're too acidic, your chemosensors will try to restore your body pH by increasing respiration to try to breathe out the CO2. And if you have a lot of amino acids and free fatty acids in the blood, but not getting into your cells, your liver will synthesize ketones. And this also obviously goes into not enough glucose in the blood. But your liver will synthesize ketones, and ketones are ketoacids, and so that will also contribute to the acidic pH. And having ketones or ketoacidosis actually causes your breath to smell sweet and fruity. And that is it for this chapter. Thank you.